37-year-old female, investigation for headache, neuro examination normal. This is her MRI and axial cut with injection of the contrast. We can see the lesion with the contrast enhancement over the left mesiotemporal lobe region, and a image suggestive of a small AVM nidus and probably a draining vein draining towards the vein of Galen. And we can see the nidus appearing. There is a certain distance between the main trunk of a PCA and the nidus. This one probably is the dilation, venous dilation. But we can see that venous dilation is ahead of the nidus, and the main venous drainage is behind the nidus. And this is her angiography, left ICA angiography. We can see here on the left is the frontal view, and on the right is the lateral view. We can see that this patient presents a fetal type of PCOM, and then this is a PCA, and we can see that the nidus is predominantly lateral to the PCA. It's on top, but it's more lateral. And here we can see an image, probably that the dilation, venous dilation, that is located anterior to the nidus. And the draining vein is going to drain towards the vein of Galen. And here we have the lateral view. Once again, the phenotype of PCOM, and then PCA, and this is the continuation of PCA. And then we can see the nidus predominantly located above, at the level just a little below, but most of the nidus is located above the PCA. Here we have the lateral view of the angiography, early arterial phase, and then let's go to the right, a bit later arterial phase, where we can see the same nidus over here, and then we can see that the venous dilations located in front and a little bit inferiorly, and then we can start looking and seeing the venous drainage of this AVM is predominantly located above, and it drains medially towards the probably vein of Galen. So we can see here straight sinus. So the venous drainage is more above and behind nidus, and there's a venous dilation located in front and a little bit below the nidus. And here once again the AP view. Now we have a better view of the nidus here, lateral to the main trunk of the PCA, and we can see that the vein is draining at the superior part and posterior part of the nidus and draining medially, first medially and then for a series of turns to eventually finally to drain into the vein of Galen. And this is that venous dilation is located in front and also a little bit below the nidus. So this is the situation we have here. So once again, now is this late arterial phase. You can see the basilar artery and PCA, but you can see much better now the nidus. You can see that venous dilation anterior and inferior to the nidus. We can see also here the draining vein is located above and then behind the nidus. It drains toward the vein of Galen that we eventually will drain to the straight sinus. This is a lateral view, and now we move to the right side. This is the AP view or frontal view. You can see here this is nidus. This is the vein on top and behind, and then it drains medially and then posteriorly to finally make a loop to finally drain into the vein of Galen. So once again, the AVM is lateral to the trunk of PCA, and this is located at the Parahippocampal gyrus. Once again, this is her MRI axial cut. The nidus is located in front of the main draining vein. And here on the coronal cut, we can see this is the nidus and then it's draining vein. The medial part of the temporal lobe can be divided into three parts. One is the anterior one is the middle, one is the posterior third. So the anterior third can be accessed through the Terrionic approach, Transilvian approach. The posterior third can be approached via interhemispheric approach. The problem is the middle one. The middle one is difficult to reach from front and difficult to be reached from behind. So what would be the best approach for this region? So how about a subtemporal approach? Here we have a specimen with a spatula. You can see it's a transverse sinus, the sigmoid sinuses. We are on the right side, right temporal lobe, right frontal lobe, right parietal lobe, right occipital lobe. Not only we have to make a retraction to go to the Parahippocampal gyrus, and then we will put in danger those vena labae and other bridging veins that will drain the brain into those sinuses. And beside of this, the presence of the bridging veins, vena labae, the thing is you have to go under the temporal lobe, and then in order to reach here, you have to go up. So you go up to down and then go up again to reach this part. This is very difficult, and it will certainly require a greater retraction of the temporal lobe. Putting, we can place vena labae and other bridging veins in danger. So how about the idea of approaching the middle third of the mesotemporal lobe region from below, from the supracerebellar transtentorial, by opening the tentorial or by removing the tentorial. So you can have a direct view of the basal surface or the medial surface of the temporal lobe. So if we approach any lesion over the middle third of the mesotemporal lobe region, just like here, by removing the tentorium and by approaching above the cerebellum, we will have this kind of view. This is a vein of Galen. This is splenium of corpus callosum, located above the vein of Galen. And then we have the isthmus of the cingulate gyrus, pulvinar of the thalamus, basal vein, and then we have this lingual gyrus at the level of the splenium of the corpus callosum, and we have the parahippocampal gyrus and then fusiform gyrus. And the veins involved in this axis are the inferior hemispheric veins. Okay, so this might be a good idea to approach lesions of this area, the middle third of the mesotemporal lobe region. And so this is the skin incision and positioning. The patient is in semi-sitting position. So here he's already coagulated and cut inferior hemispheric vein. Now he's opening the thick arytenoid membrane. We can see that this vein, this is draining vein, arterialized draining vein. And now he's opening the tentorium. And first coagulating the tentorium, all, and then cut. And we need that very good support of the anesthesiologist to prevent the air embolism. Now he's cutting, coagulating, cutting the tentorium. And then this is vein of Galen. This is finally the tentorium has been removed. Now this is the draining vein, arterialized vein, and this series of turns is indicating that this is the posterior part of the draining vein. It drains towards the vein of Galen. So now he's working on this posterior part of draining vein. The lateral part of the draining vein has been freed. So anything that goes towards the draining vein is coagulated and cut. Now the vein is freed, so can be mobilized. It drains toward here, not here. So now he's coagulating, but not the draining vein itself. So now he can mobilize the and dissect the lateral part of a draining vein. This is the vein of Galen. And now he's separating the draining vein from the basal vein. This is the basal vein. And this is the horizontal part of the draining vein that goes medially. So we know that nidus of the AVM is located more lateral and anterior to the draining vein, the horizontal portion. In this position, up means posterior and down means anterior. So this is that horizontal part of the AVM, of the draining vein. And now he's following a branch in an inferior temporal artery, and at this stage, this is the inferior temporal artery. At this stage, the draining vein has been coagulated; it's gone already. So now he's coagulating and cutting all the branches arising from this inferior temporal artery, and that goes to the nidus. So another branch to the nidus has been coagulated and cut. There's no draining vein anymore. It's been coagulated over here, but the flow of the artery probably is not good enough. It's not big enough to cause swelling or intense bleeding. Now continue to coagulate the nidus. We know that the nidus extends laterally through coagulation and cut and preserving the inferior temporal artery. Coagulating, and this is a basal vein. And this is a branch of PCA. Be careful. Basal vein, PCA, following this inferior temporal artery, and coagulating all the branches from this artery to the nidus. Coagulation, cut, coagulation, cut. Then it's dissecting the nidus and continue to dissect, and it's cleaning, coagulating small branches going to the nidus, and then coagulation, cut. And little by little, he can mobilize the nidus. And then this part is attached to that venous dilation down here. So finally, he will coagulate and cut to remove the nidus. And then later on, it's not in this tape, but he will remove that venous dilation down here. So now the nidus has been removed. Okay, nidus has been removed. And then this is the final aspect after the removal of that venous dilation. On the left, we have the preoperative angiography, and on the right, we have the postoperative angiography showing the total occlusion or removal of the AVM. And she remained neurologically intact after the surgery. And for those who are interested in this supracerebellar transtentorial approach, you can see this paper published by Dr. Evandro and his co-workers in March 2012 in Journal of Neurosurgery.